Alhamdulillah.
Ya.
Udah mulai kok. Silakan Dr. Maizan, mungkin mau dimulai. Gimana Pak Ketum saya?
Oke, mulai aja kan masuk YouTube kan sudah.
Oh, siap. Sudah masuk YouTube ya. Siap. Professor Datin, are you there?
Nah, apakah bisa dimulai, Dok?
Bisa. Silakan.
Good afternoon, everyone. Welcome to Update Management and Knowledge of Stroke Event. Here we have Professor Datin from Neuroinfectiology Heldenberg, and we have Dr. Ricky Busanto Kurniawan, a neurologist consultant from Pond Hospital, and of course we have Dr. Adip Kumaidi, orthopedic consultant, as chairman. So today we have update knowledge and management of stroke event. As we know, stroke is one of non-communicable disease that have a big impact in our community. So first of all, I want to have a warm greeting for Dr. Muhammad Adib Humaidi as the first speaker. Hello, Dr. Muhammad Adib Humaidi. Good afternoon.
Dr. Maizan, thank you, Maizan. Dr. Maizan. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, especially for our honorable Professor Lamade. Danke, you can join with us. Thanks. And my best friend, Dr. Ricky, from the National Center of Brain Hospital, neurologist. My friend, Dr. Wirawan, and para teman sekalian yang ada pada sore hari ini. Ya, alhamdulillah kita bisa bertemu pada sore hari ini untuk berdiskusi. We join with the Professor Lamade from the Neuroinfectiology Automation Hof Center, University of Heidelberg, Germany, and Dr. Ricky from the National Center Brain Hospital in Indonesia. We want to sharing how to manage and update knowledge about the neurology management, especially in the stroke management. Because you know, in Indonesia, stroke is the leading cause of death for people aged above 5 years old, which is around 15.4% of all death. This is based from the data from the Ministry of Health in the 2019. And the prevalence of stroke in Indonesia is 10.9 for every 1,000 citizens. I think it is very big in Indonesia. So with the meeting, and I hope from the Indonesian Medical Association could be joint relationship with the Professor Lamade in Germany about the increasing the knowledge, especially for the medical doctor in Indonesia, GP or specialist, and maybe we can join relationship with the how to manage and sharing benchmark about the services in the stroke. Thank you, Professor Lamade.
Thank you.
Time.
Okay. Thank you, Dr. Atip, for opening this discussion. Now, let us hear from our first presenter, Prof. Datin Dr. Matt Meiding Lamade. Guten Tag, Professor.
Guten Tag.
Yeah. Prof. Datin is a professor in neurology. She is the chief of neurology department at Northwest Hospital, as well as a director of International Institute of Medicine and Telemedicine at Northwest Hospital, Frankfurt, Germany. She also worked as neuroinfectiology specialist at Heidelberg University. Also in Brunei Darussalam, Prof. Datin led Department of Neuroscience Stroke and Rehabilitation Center for 10 years. Furthermore, in Brunei, she contributes her knowledge as a visiting professor at University of Brunei. Prof. Datin is an active member of Drug Commission of German Medical Association and leading the Committee of Digital Neurology and Telemedicine of the German Society of Neurology. Before the presentation starts, I will inform you the game plan of the presentation. First, we will hear from the presenters, Prof. Datin and Dr. Ricky, and when the all presentation finish, we will start Q&A session. Prof. Datin, may you start your presentation?
Thank you for your introduction. Thank you, Mr. Chairman, Mr. Kumaidi, and thank you, Viravan, for arranging everything, and thank you, Dr. Ricky Kunyavan, for the to share my presentation. Can you see anything? Can you see it now?
No, still not.
Can you see it now?
No, Prof. Maybe Dr. Farhan could you co-host with the Professor Lamade?
You can't see?
We still cannot see.
Haben Sie auch vorher freigeben?
Ja, habe ich.
Bildschirm freigeben.
Yeah.
The host has to activate that I can share my screen. I'm deactivated, so I can.
Please host give permission for the Prof. Datin for share the screen.
It's still deactivated. I just try once more.
Jawohl.
Ja, jetzt.
Okay, Prof, you ready?
Freigeben. Den Desktop, ne? Freigeben.
Yes.
Jetzt müssen wir wieder You can see it?
Yes, we see it.
Good. Okay. All right. So we start about stroke. I'm happy this you already got my CV. I personally think that we should go together despite the current political situation. The world will be always strong when we go together like these paragliders who cooperate instead of confrontate. No, I can't go further. Okay, effective treatment in stroke. Is it available all over the world? It is not. It is a real bottleneck. The availability of qualified neurologists, neuroradiologists, interventionalists is not available all over the world. And as time matters, it's one of the most important aims for health system all over the world to get this available for the patients, because there is no time to fly anyone away to another place. This is a stroke mortality. It's 2019 published and in Lancet 2021. And you can see dark red is a high mortality. If you suffer a stroke in those areas, you have a high risk to get a very severe stroke. Whereas in the areas where you have a good stroke treatment available all over, you have a dark blue or bright blue color. And what you can see here is that even in the Scandinavian islands, which is, I think, a little bit comparable as well to Indonesia, one was successful to establish a good stroke treatment, but very important, the active stroke treatment has to be used in the acute stroke. So we fight in the first minutes and the first hours. It's very common. 1 in 6 persons suffers a stroke. And I put these wonderful fruits from your area here to illustrate it. If you see to dementia, it's even more common, but stroke 1 to 6, it's a big number. And you all know the symptoms. It's very easy to recognize a weakness of one side of the body, a facial asymmetry, speech and language disorders, or visual disorders. If you know those 4 items, you will discover 90% of stroke patients. There are 2 different kinds of strokes. One is bleeding, and the other one is a reduction of blood to the brain. It's called ischemic. Those are completely different and they are treated different. I will focus on the ischemic part of stroke because those are the stroke patients where we have to offer a lot. So this is a typical example. On the right side, 20% of strokes, you have a bleeding. On the left side, you have an ischemia. That means no blood comes to the brain tissue. And that is very important because you can salvage brain tissue within the first hours, not after days. Definitely, there is no acute treatment in a so-called chronic stroke. It's only be treated in the acute phase. Very important. The stroke therapy is a teamwork. Like I see the chairman and Dr. Kumaidi, you orthopedic, neurologist, it's a teamwork. If you want to do good medical service, it's never one person alone. For stroke treatment, we need a good neuroradiologist, we need a vascular surgeon, we need neurosurgeons, and we need neurologists, of course, but we need therapeutic staff and nursing staff. What is very important, because the most common reason of death after stroke is pneumonia. Why? Patients have difficulties to swallow what you can't see, and relatives bring some good apples, some good fruits, a piece of meat. Patients have swallowing difficulties, get aspiration pneumonia. What do we do in acute stroke? There are many very well investigated treatments. Early aspirin, but only after you have got an image, never at home, because you don't know, is it a hemorrhage or is it ischemia? Don't give anything. If there is a clinical suspicion, you need diagnostic. Treatment in a specialized stroke unit is a very high evidence systemic lysis in the first hours of acute stroke, thrombectomy in the acute phase. That means you go with a catheter to the brain and pull the thrombus out, the clotting which obstructed the vessel, and operation where you take a handful skull away. So the stroke, which is causing a swelling of the brain, if your one side of the brain is damaged, and it's like a walnut, the big bone, so the damaged brain goes over to the healthy side and you get a damage on the healthy side. Therefore, very early, we do hemicranectomy in stroke with a very good result. It is shown that even if you have only transient symptoms, a weakness just for 10 minutes, and then everything is over. Patients tend, especially when there's a famous football game at the TV, they tend to stay at home. This is a mistake because in 30% of severe strokes, those transient, only lasting a few minutes symptoms are predicting a very severe stroke in the next hour or next hours or next week. So those patients are still an emergency and have to come as emergency to the hospital. The relative risk reduction after such, it's called TIA, transient stroke, is 80%. We don't have often percentages like this in medicine. So this is an emergency. It has been since many years known, 2008. Thrombolysis, what do we do? First of all, there is some lost tissue. We can't do anything. Therefore, thrombolysis done months or weeks after stroke is a big mistake. You should not do it because the tissue is lost. But in the early phase, we have a tissue which is called penumbra. And that means it is still enough to keep the metabolic system of the brain going, but it's not enough to survive a longer time. And this penumbra tissue, that is a tissue we reach to salvage by thrombolysis, not the lost tissue. Lost tissue is lost, but penumbra is a tissue at risk. And here we have a very narrow time window where we can do thrombolysis in general, 4.5 hours. We have special protocols with MRI. Wake up stroke is treated as well with thrombolysis in specialized settings where you have so-called mismatch. I won't bother you with too much details, but it's a acute treatment. That is important, very important. If you don't offer to your patients this acute treatment, the effect is lost for 7.5 years. So those patients who have got thrombolysis compared to those patients who did not get thrombolysis are very different in the mortality rate, even 7.5 years. So it's a long-lasting effect. And this is the outcome according to minutes. As you know, in medicine, Viravan, you are a doctor and a businessman, so you know best, but everyone knows economy is important too. And what we do in medicine nowadays is that you calculate how many patients do you have to treat to get one patient with benefit. I give you an example, heart attack, 22. You have to treat 22, one gets a big benefit. In stroke, if you do the thrombolysis within 90 minutes, here you can see on the graph, you only need 5 patients to get a huge benefit. So those 90 minutes, 1 hour and a half is very effective. And this number gets very soon up. After 360 minutes, 21 patients have to be treated, that one gets a benefit. So time is crucial. You don't have time to send patients away to other countries. We call this concept brain attack concept. We want to treat early and we want to be effective early. We don't want to waste time for waiting weeks or even months. Here you can see an example, a swelling of the brain. It's just huge stroke. Here you can't do thrombolysis because the tissue is already gone, but you can salvage a huge part of the brain, which is not effective, by this so-called hemicranectomy. You see the operation room, you see the swollen brain The skin is done with a zigzag suture, so it's an enlarged skin suture. And then in the morning, it looks like this. The patient already has gone a cooling temperature. We do hypothermia as well in our department, very specialized treatment to cut down the metabolism of the patients, but this is only in high-end centers available. And in the morning, when I go to walk around, I can touch the brain. If it's very swollen, I know there is still increased brain measure. Of course, we do specialized intracranial ICP measurement. We measure it with technical equipment, but you can put your hand on the brain and you will feel it. Surgical decompression treatment reduces mortality up to 70 years of age. So even in the old population, we do it even in elderly people when they are fit in a good shape. And you only need to treat 2 to get 1 effect. Mechanical recanalization, that is one of the very exciting procedures we have been performing since many, many years, but now it has been proven by very different strokes in different countries. A very good example for cooperation. All trials put their data together, so they were much faster to get the result. Number needed to treat is only 4, very effective in a special group of patients. So about 15% of ischemic stroke patients are eligible for this treatment. It's not the majority, but in those good selected patients, you have a wonderful result. We had yesterday a patient, 80 years old, coming in with hemiplegia, couldn't move at all, big thrombus in the vessel. It was taken out. Patient was to come to our center with a helicopter. And this morning, when I come to Vaudran, the lady is sitting at her bed. That is wonderful, great success, but you have to do a good selection only in the acute stroke phase. Why do you do mechanical recanalization? There's an occlusion, the vessel is occluded, there's an obstacle in the vessel. Mostly it comes from cardiac thromboembolism, and often if you don't do anything, you will get a huge infarct, and you can aspirate this thrombus, take it out of the vessel, and you can combine it with thrombolysis. It's called bridging treatment. Afterwards, you do different kind of treatments for the patient. Eligible, according to center, between 5, maximum 10 to 15 patients. So it's only a small part of the patients. This is a typical example for a reopening setting. It's a hybrid operation theater. And here you can see the catheter system, which retracts the thrombus on the left side in the bottom. You can see it's a carotid T occlusion. It's a huge brain occlusion. Cerebri anterior, cerebri media was occluded. And after the procedure, you can see the nice vessel tree. If you look the acute stroke care in Germany, there's a huge success concerning the number of mechanical thrombectomy. We did over 10,000 intravenous thrombolysis. You can see a huge number, and the stroke unit care, you can see a huge number. We have about 250,000 stroke patients a year with a population of 80 million. Of course, Indonesia is much bigger, so you will have much bigger figures. No thrombolysis without stroke unit. You have to have a specialized unit. No thrombectomy without possibility to perform the other procedures. So it should never done in an isolated setting, only doing catheter procedure without a stroke unit. No therapy against each other. They are not competing. One builds upon the other. Post-stroke treatment is important as well. Rehabilitation is important, of course, in the phase after the acute stroke. And we know nowadays that we use different secondary prophylactic medication. In high-risk patients, we use a combination of clopidogrel plus aspirin. This is a so-called point study. And now a few pictures out of Brunei. This was a building which was built for stroke and oncology. Here, ICU setting. Not only elderly patients, young patients get stroke too. 15% are younger than 40 years old. One example is systemic lupus erythematodes, very common in the Asian population, in children as well. Those patients get severe vasculopathy. This was one lady, she gave permission to be shown. She was treated with a very highly immune treatment in Brunei Darussalam, and we built up a center of excellence there. We did teleneurology, which is especially in stroke, very well feasible. One of the reasons why in Scandinavian countries stroke treatment is so well performed, because remote doctors are advised to perform thrombolysis, are helped to select the patients. You can do a lot with tele-education. We did a specialist of neurology curriculum. We did an epidemiological study, very interesting. 20% of 20-year-old people in Brunei Darussalam had high blood pressure, not recognized, not treated. And as you know, this is one of the major risk factors. We did a lot of tele-rehabilitation in the so-called chronic stroke. This is very important, very effective. At the moment, I started together with Mount Sinai and Johns Hopkins a project in Zambia where we built up completely different, of course, different setting, not comparable, of course, at all with Indonesia, but very effective as well. Stroke treatment is highly specialized. You have a very different approach in the acute stroke and in the time period post-stroke. Very different approach. Acute stroke treatment is only confined to the acute stroke. The weakest point of chain puts everything at risk. I'm not a specialist in oil platforms, but I guess when one of the most important pipelines is breaking, everything is lost. And that is the same in stroke treatment. It has to be a cooperation of many different players who treat according to good guidelines. So this is my presentation, and I'm looking forward to the discussion. Thank you for your attention.
Thank you very much, Prof. Datin, for giving such an informative and interesting presentation about stroke management in Germany. And now let us hear the neurologist from our country. I welcome Dr. Ricky Gusanto Kurniawan. Good afternoon, Dr. Ricky.
Good afternoon. Thank you very much.
Dr. Ricky is a neurologist and has fellowship in interventional neurology and stroke. He works at our National Brain Center Hospital in Jakarta, Indonesia. Dr. Ricky, you may start your presentation.
Is my presentation has been seen yet?
Yes, already, Dr. Ricky.
Thank you very much to everyone, especially for Dr. Adib and Professor Datin. My name is Ricky Gusanto Kurniawan. I'm from National Brain Center Hospital, Marmarjono, Jakarta. I will discuss about the overview, the hyperacute stroke management. Actually, it's already been presented with Professor Datin, and it's very easy to understand. Thank you very much, Prof. It's more easier for me. Okay, as we know about the epidemiology, as stroke is the most common cause of death, exceeded by only by the ischemic heart disease, even in US or Europe or China. But Indonesia, it's very, very different. From 2009 until 2019, stroke is #1 of the has the cause morbidity and mortality in Indonesia, which is mostly patient with morbidity has a burden to the country, or even for the family, because they cannot doing jobless. They are jobless, and then Some even they cannot do the activity living, daily living. So this is very, very important thing about the Indonesia. The incidence of stroke type, which is we all know the ischemic stroke, as Professor Datin said that it's 80% in the world. About the active 7%, it's almost the same with our hospital. About the more than 86% is stroke, is ischemic stroke, and the only 13% is hemorrhagic. This is the current guideline that we use, very common in almost every country, that we use from the AHA guideline or European Stroke Association organization. Both of the standard guideline, almost every country is direct to the based on make their national guideline based on these two guidelines, and then it depend with the resources of the country itself. From the guideline, the most important thing about the stroke recognition, as Professor Datin said that before, the most important thing is the optimization stroke management in golden period. What we should do, first we have to recognize the clinical manifestation, the quick transportation, and the quick management in hospitality. In Indonesia, until now, there is still the recognition about the stroke is still the problem. This is a stroke campaign. A lot of countries have their own stroke campaign. As all I know, even in Germany, there has a stroke on stroke campaign. But at the first, it's become from the this is fast stroke from the NHS, and then from the Indonesia we make some point like this one with the segera ke rumah sakit. With it, the message is it should be easy to understand, easy to remember, so the target, the general public, so they can recognize about the stroke, so they can go to the hospital as quick. This is fast recognition. This is very popular. For the first we face, arm, speech, and time. Yeah. From the face, we can see the fallen of the one side. The arm can raise both arms and keep them there, or even there is slurred speech, or even cannot speak. So if there is this kind symptom, we need to call the ambulance or go to the hospital as quick as possible. In Indonesia, we added some symptom like another country, like hypoesthesia, and then this is visual problem, or even we added headache with the severe headache. So if there is any symptom of this, the patient should go to the hospital. What is the golden period of stroke? Golden period of stroke, basically, without thinking what is the pathologies, either ischemic or hemorrhagic, every stroke patient needs quick management because of probable morbidity and mortality. Short time of golden period of stroke, which is only 4.5 hours, especially for the ischemic stroke. Why this only short period time? So we can see it. There is a motto, time is brain. We can see in here, every hour, 120 million neuron will be irreversible. for the large vessel occlusion, yeah, every hour. So we have to be quick to save the neuron. In golden period of stroke, what we have to save? The goal is to save the penumbra before it becomes irreversible. As we can see, this is the core. The core is mean that the part of the brain which is it cannot be saved again, non-salvageable. And the other is penumbra. The penumbra is the area of the brain there is a hope for us if we can do the recanalization, so the penumbra can be saved. The important thing, the message of this slide is not only the recanalization, the important thing. The goal of this is we can save the penumbra. Recanalization, for example, we do the thrombolysis or even thrombectomy. It's only the way how to save the penumbra. Because if we wasting the time, the penumbra will growing to be the ischemic core and it cannot be saved again. Well, this is the algorithm that we use in our hospital, which is we divided into time with the onset. This is what kind of the imaging that we choose for this for the patient. Yeah. How about if the number to treat, like Professor Datin said there before, at least in 19 minutes we have to number to treat 4 to 5, and then more time we wasted, so the number to treat is more growing. So it's very depending with the time. Like Professor Datin said, the stroke team is very needed. It's not only the neurologists who can do it, but it needs a lot of teamwork for the nurse and the laboratory, radiology, or even neurointervention, which okay. Let us talk about the treatment window in less than 4 hours, 4.5 hours. From the evidence base, based on the AHA trial, AHA guideline or ISO guideline, the IVTPA for acute stroke is only the FDA-approved therapy for the treatment of the acute stroke, which is less than 4.5 hour window for treatment. This is very, very short time. So usually when patient come to a hospital, it should be less than 6 minutes door to needle, which means it's already given the thrombolysis, IV thrombolysis. Yeah, early treatment increase chance of good outcome. So like Professor Datin also said, that it's very, very favorable outcome for the thrombolysis, IV thrombolysis. And it is time, very, very time dependent. As we can see, this is number to treat. Every minute is ticking. The clock is ticking. Is very need to. This is the IVTPA. IVTPA in Indonesia, we have only Achilles. The indication is less than 4.5 hours. And the second one, how treatment if more than 4.5 hours? What we can do about it? As we can know that the eligibility for the IV thrombolysis is less than 4.5 hours. And how about if more than 4.5 hours? What we can do about it? From high guidelines 2018 recommendation or even ISO guideline European Stroke Organization 2020, the recommendation is do the mechanical thrombectomy. It is class 1A. And this is the eligibility of the mechanical thrombectomy. Not every person we can do the thrombectomy, of course. Not every patient that we can do the thrombectomy. It should be the large vessel occlusion, large vessel occlusion. And it's the criteria with more than 6 hours, the indication indicate with the it should be fulfilled with the down criteria or diffuse criteria, which is this is using the CT brain perfusion. And how about the mechanical thrombectomy? This is the number to treat entity about the number. It is very, the hope is very good. The outcome is very good if we success do the medical thrombectomy with the eligibility patient with good outcome. So what we can do about the medical thrombectomy? From the guideline, there is 2 techniques that we can do the mechanical thrombectomy. First with the stent, reversible stent, and the second one with the aspiration catheter. Or usually, sometimes we use both this technique, not only one technique. And he had 12 trial thrombectomy versus control, and with the endpoint disability is more than 90 days. MRS is very good. The death is favor prevention. The number to treat is 5.4. And this is very satisfying because as we all see, as we all know about the large vessel occlusion, so the clinical manifestation is very severe. So if we succeed, it's very helpful for the patient. So what is mechanical thrombectomy indication? Mechanical thrombectomy indication is for the large vessel occlusion. It's only for large vessel occlusion and less than 6 hours. It can be extended with presenting between 6 and 24 hours from time last known patient in well condition with fulfilling inclusion criteria for diffuse 3 and down clinical trial, which is depend with the CT perfusion, which is we have to know how many penumbra that we can save, the mismatch of the penumbra and the core. This is the effectiveness about the IV TPA with plus with the thrombectomy, and almost all it's good outcome. There's another trial. The conclusion of this my presentation is the minute I can save life. This is the learn the sign and say it a stroke. So the precious time is very important from the recognition of the stroke and the management of the stroke. So the reperfusion can be done, and the goal is we can save the penumbra. Thank you very much.
Okay, thank you, Dr. Ricky, for the excellent presentation. Now we all have heard the latest stroke management from both countries. There are few similarities, but each country has its own characteristics. Therefore, now we can start with Q&A session. I can see there are a few questions. I appreciate for this question. However, we are only able to accept maximum 3 questions for the time efficiency purpose. And Prof. Datin, I already answered some question in chat box, but some question unseen in the chat box. I will read it. Here's the first question. The first question is for both Prof. Datin and Dr. Ricky. Is heparin could be a potential therapy for stroke because DSA or intra-arterial heparin flushing a protocol of managing stroke it is famous in Indonesia, especially it brought by Dr. Terawan. Please, Prof. Datin and Dr. Ricky.
For the acute stroke, we do not use intravenous heparin. This is a treatment we used to do many years ago, before we had the very specialized thrombolysis indication, very specialized thrombectomy indication. And in most of the cases, we use aspirin in acute stroke patients. There are a few selected patients, like young patients who have a dissection of arteries, where we sometimes still use anticoagulation, but normally not with heparin. We use other drugs for this. But this is a very small part. And to be honest, in those dissections, we do not have controlled trials, but we do it in some of the cases. In general, either we do thrombolysis, thrombectomy, and we put as secondary prophylaxis aspirin. The aspirin is not directed to recover the stroke, but to prevent further strokes, because we know in the acute phase of a stroke, the recurrence rate to get another stroke is much higher in the first week, and then a little bit higher in the first 3 months. And after your 3 months, you have your life risk. And therefore we use aspirin.
That's very clear answer, Prof. Datin.
Yes.
Thank you. And Dr. Ricky, maybe.
I think Professor Datin is already very clear and easy to understand. I very agree with Professor.
Okay, thank you for the answer, Prof. Datin and Dr. Ricky. And we can move to second question. Second question is for both Prof. Datin and Dr. Ricky too. Is there any reported risk of the adverse event occur in the administration of heparin for DSA? Or maybe they mean the side effect? Please, Prof. Datin and Dr. Ricky.
In the DSA, this is a diagnostic tool. It's not a treatment. DSA only means you put contrast media to the blood vessels of the brain and you look how the vessels look like. And the DSA can be used to apply treatment, and normally we give, for example, thrombectomy as treatment in very, very rare cases, for example, in migraine patients who have severe occlusion. Sometimes we give nimodipine intra-arterial, but these are very selected cases, and there is no indication in general to put a catheter in the brain and just infuse heparin. That is not done in acute stroke.
Can I add in?
Yes, please.
Yes. Yeah. Thank you very much,
Okay, please,
Professor
Dr.
Datin.
Ricky.
Thank you very much. Yes, like Professor Datin said, the DSA is only for the diagnostic. So we use the catheter line into the femoral artery. As we all know, that because we use catheter inside of the lumen artery, so it can be harmful. It can be some thrombosis. So we usually, there is a standard that we use the heparin to take about this risk. So it's actually we never thinking about the therapy until now. It's only we give the heparin is only to reduce the risk, because we use the catheter, not for the therapy or something. I think that's the only thing that I can say.
That is a very important point, Dr. Ricky, because you can imagine when people have old vessels, the surface is very rough. And if you go with a catheter in, it's a small catheter, it's very fine, but nevertheless, by manipulating mechanically along the vessel, you may even cause strokes. And therefore, we do a low dosage of heparin to protect, but not as treatment. And therefore, we really look carefully who needs angiography. And there are indications for angiography. For example, when you have infectious reasons of stroke, this is not common, but it occurs. For example, in dengue fever, you can get it sometimes. Then you might want to look at the peripheral arteries, and then you need a diagnostic angiography, but not as a routine treatment in every stroke.
I agree, Prof. I agree.
Thank you, Prof. Datin and Dr. Ricky. So I got the point. DSA not for treatment, just in very rare and selective case, and not for general stroke treatment or basic treatment, right? And we move to our last question. Our last question also for both of you. Digital subtraction angiography came back with a good result in Indonesia. What's your opinion about this? And is it okay to preventive therapy in patients without any symptom? Please answer, Prof. Datin and Dr. Ricky.
The clinical symptoms of the patients are the gold standard. If a patient has no symptom, we are reluctant. There are indications, for example, when you have very severe narrowing of a neck vessel and a patient has a speech arrest for 30 minutes, which is called a minor stroke or TIA, then you will go on and operate this, but you operate it with a real surgeon, for example. So in general, we treat when there are symptoms. And angiography in patients just doing like this is not indicated in stroke treatment. And we have to say that, like Dr. Ricky was citing, and I was citing, I'm educated by Werner Hacke, who long time was president of World Stroke Organization. And there are many, many clinical trials running all over the world, double-blinded, with many scientists getting really good results and clear evidence, level 1A, like Dr. Ricky just presented in his talk. And those are the treatment which should be done. I'm always a little bit skeptical with single center trials because you never know. There have to be different centers coming out with the same result, double-blinded, peer-reviewed, and carefully checked out.
Okay, maybe Ricky want to add some opinion?
I don't know what I can say again. Professor Datin has already said very clear, very. Thank you very much, Prof.
Yeah, it's very clear. Yeah, I got the point is the SA not for therapy in patient without any symptom because it could have side effect too. It's very clear from Prof. Datin and also from Dr. Ricky. Thank you for the answer. And all right, let's conclude the Q&A session. And finally, we come to the end of the webinar. Because closing this discussion, I want to draw conclusion from what speaker said is, Stroke is number 2 killer in the world and number 1 in Indonesia. A stroke is dangerous for life and limb, both ischemic and hemorrhagic stroke, because it's rising in seconds. In Germany, to treatment stroke, they work as stroke unit. But in Germany and Indonesia, stroke is differentiated to acute and time period. In acute stroke, good team and speed are the key point of the successful prognosis. The management based on evidence-based are early aspirin, treatment at specialized stroke unit, systemic lysis, thrombectomy, and hemicraniography. And in addition, in Indonesia, we try to know and identify the symptom of stroke. We can see that the management of stroke is aligned between Indonesia and Germany. We don't use intraheparin flushing in acute stroke. We need to do double blinded final to determine the protocol. That's all what I can say, and I would like to give our greatest appreciation to the speaker, Prof. Datin and Dr. Ricky, for their informative and interesting presentation, and all the participants for their enthusiasm and very active participation. And please, our host, Dr. Mason, to close this discussion.
Thank you, Dr. Cynthia. Thank you very much for all speakers. It was excellent presentation that bring us a new perspective in knowledge and management of stroke event. It was very clear explanation from all the speaker, and we hope all participants could use this evidence for our medical practice. Thank you, Prof. Datin. Thank you soon. Thank you, Dr. Ricky, and also thank you, Dr. Cynthia, for moderator for today's special event. And also, we really appreciate to all participants that stay tuned until the end of webinar. So, in the end of this webinar, we invite all the speaker and all participants to join photo session. So, to all participants, please turn on the camera. Okay, we have a photo session with Prof. Datin and Dr. Ricky. Okay.
Fotomu.
Okay. Ready for photo session? Okay, 1, 2, 3. Smile. Okay. Okay, the next page, the second page. 1, 2, 3. The third page. Okay. Thank you. So on behalf of Indonesia Medical Association and our presenter, thank you for joining and see you on the next upcoming webinar. Have a good rest. Thank you. Thank you, Prof. Datin.
Terima kasih. Thank you.
Thank you, Prof. Thank you, Dr. Adit.
It was nice to meet you. Thank you. All the best.
Nice to meet you also.
Thank you. Have a nice one.
Bye-bye. Bye-bye.
Terima kasih, Dr. Tera.
Terima kasih.
Dr. Saprizal, terima kasih.
Pancing.
Terima kasih.
Loh, udah selesai ya?
Tolong moderator kesimpulannya dibagikan.
Cuma 30 menit ya?
Untuk terawan PSA tidak itu.
Baik, izin untuk mengakhiri Zoom ini.